Okay. All right. Well, welcome to this afternoon's, or depending on where you are, maybe it's still morning. Welcome to this webinar presented by SAMHSA's Gain Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And today our focus is on screenings and assessments for substance abuse disorders to support successful reentry. And our presenter today is Dr. Roger Peters, and I will introduce him shortly. But first, I am Dr. Melissa Stein, a Senior Project Associate with Policy Research Associates in SAMHSA's Gain Center. And you will see a chat box icon at the bottom of your screen. Feel free to use that chat box to introduce yourself and where you're joining from. I'm joining from outside of Charlotte, North Carolina. And before we start our presentations, I have some introductory items to review. First, the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. And throughout our presentation, we welcome you to submit questions in the Q&A pod. Again, there's an icon for the Q&A pod at the bottom of your screen, and the presenter will address as many of your questions as time permits at the end of the presentation. We'll also be conducting a couple of polls throughout this event. You should have just seen one pop up on your screen right now. Just select and submit your responses, and we really appreciate you participating in those polls. We are recording today's webinar, and it will be posted to SAMHSA's YouTube channel, and we will notify you of the link to access the recording following this event. We will also disseminate slides to all webinar registrants in weeks following this event. We will provide a certificate of attendance for download at the end of this event. This certificate is for your personal portfolio. We are not able to issue CEU credits. We do have ASL interpretation for this event. Our interpreters today are Dave Glatzer and Pamela Mitchell. We also have live transcription from Zoom available. To see that, just click the live transcript CC and then select show subtitles. Next, I'd like to turn it over to our representative to provide some opening remarks on behalf of SAMHSA. Amy Romero is a subject matter expert in the criminal justice programs and a public health advisor at the Center for Substance Abuse Treatment at SAMHSA. Amy.
Welcome everybody to today's webinar, Screening and Assessment for Substance Use Disorders to Support Successful Reentry. Individuals living with substance use disorders who are reentering the community from jail and prison often encounter significant barriers to behavioral health treatment, safe and stable housing, meaningful employment, and other recovery support services. The use of evidence-based approaches for screening and assessment is likely to result in more accurate matching of clients to treatment services and more effective treatment and supervision outcomes, as well as many other needed services for our clients' recovery. So we're very excited today to have this webinar presented by Dr. Roger Peters that will cover the importance of screening and assessment, the different tools that are available, and how to use the screening and assessment results to develop reentry plans. These are very important topics, and we hope that you find them very useful for your day-to-day work. We would also like to thank the Gain Center for all of their efforts and for coordinating this webinar. So I will pass it back on to Melissa. Thank you.
Thank you. And now I'd like to introduce our speaker for today's webinar. Dr. Roger Peters is Emeritus Professor at the Department of Mental Health Law and Policy at the University of South Florida in Tampa, Florida. and he is a Fulbright Scholar and a consultant with the U.S. Department of State's Bureau of International Narcotics and Law Enforcement Affairs. And he's also a consultant with the United Nations Office on Drugs and Crime. He's Vice President of the International Consortium of Universities for Drug Demand Reduction Executive Leadership Team and the International Consortium for Alternatives to Incarceration. Dr. Peters served 4 years on the Board of Directors for the National Association of Drug Court Professionals and for 8 years on the Treatment-Based Drug Court Steering Committee for the Supreme Court of Florida. He currently serves on the Florida Supreme Court Steering Committee on Problem-Solving Courts and has been a faculty member of the National Judicial College since 2014. And Dr. Peters served as chair and co-editor of the SAMHSA CSAT Treatment Improvement Protocol number 44 on substance abuse treatment for adults in the criminal justice system. And Dr. Peters was also the lead author of the monograph Screening and Assessment of Co-occurring Disorders in the Justice System, which was published by SAMHSA and will be shared during this event. So now you've heard a little bit about who is going to be speaking to you today during our presentation, and let's just take a moment and learn more about all of you joining us today. Thank you so much for adding your comments and joining us in the chat. It looks about 45% of you joining from urban locations, followed by 32% joining from rural locations. So really wonderful breakout there. And that's followed by about 23% joining from suburban locations. We do have a few people joining, about 9 folks joining from tribal lands, such as reservations, pueblos, or Alaska Native villages. And then in terms of your agency and organization, it looks like we're seeing the leading group, about 26% of you joining from corrections, probation, and parole. Welcome. We also see about 22% of you joining from community-based provider organizations. And that's a match of about 22% of you joining from government and policy organizations. I do also see some of you coming in from judiciary, law enforcement, academia. So thanks so much for taking your time out today to learn about this really important topic. Without further ado, I'm going to turn it over to Dr. Peters to get us started. Dr. Peters.
Great, and thank you for the wonderful introduction, both Amy and Melissa. It's great to be here today with everyone. And thanks again for everyone for joining us, for taking part of your day for the webinar. Just making sure the slides work. So today we're going to review the importance of reentry screening and assessment and how that can be helpful in your work. We'll look at the different types of screening and assessment that are used during reentry and look at specifically instruments for use during reentry. I will focus my comments today on instruments that are primarily public domain, free of charge to use, because those are the most easily accessible. And then we'll talk a little bit also about the use of screening and assessment to develop reentry planning, which is something that many of you are involved in. This would be both pre-release planning, but also post-release as people enter the community and hopefully are transitioning back into reentry services. So as we move forward, I just want to make one quick comment. I'll move pretty quickly through some of these slides, and just because we don't have a huge amount of time and we have a lot of content to cover, this could be the subject of a couple-day workshop probably. And so if you'll bear with me, I'll move quickly through some of the slides so we can focus on those that are the most important. Just in starting out, I just want to mention that throughout the justice system, we want to provide screening and assessment as needed across the different intercepts. So starting with law enforcement, really, and going beyond that to look at courts and, of course, custody settings, jails and prisons, also court-based settings, other diversion program settings. Certainly at reentry, we'll be talking about today during the webinar. And then in community corrections, probation, parole, those type of settings. So each of these is critical. And of course, we'll talk mostly about reentry today, but we recognize that it's really important to provide screening and clinical assessment as needed at different points, partly because we may miss people in the early stages of screening at different points, who may be reluctant to even talk about their substance use disorders or other psychosocial problems, but may be more open as they move into different parts of the system. And so we want to have multiple points of contact to look at screening and assessment. Just very briefly, if you'll indulge me, I just want to mention the importance of reentry services, that they are so critical in reducing public safety risk and also increasing the likelihood for reintegration and connection to critical services in the community. So we know the outcomes of reentry services lead to very large reductions in substance use and rearrest. And this particular study, the first one mentioned, is during a 5-year follow-up to prison incarceration. We know that outpatient services following release can cut down the reincarceration rates by a significant amount. This is a California study. And then we know that economically, that these follow-up services during reentry provide a huge economic return for the investment. So if we look at incarceration and look at treatment provided in prisons or jails, we have significant results for evidence-based treatment approaches, but we have much magnified results if we can couple a treatment that starts in prison or jail with reentry services, as you know. So really, really important to look at. Some of the models then for reentry services, you're well familiar with these, I think. These include transition treatment centers, such as work release programs, day treatment. These interventions can really reduce prison recommitment. So as we know, most people relapse, overdose, commit additional crimes in that first 90 days after release. And without transition programs with reentry services, we have extremely high recidivism rates, particularly for those that have active substance use problems, chronic disorders coming into prison, and who aren't receiving services following release. Some of the promising interventions you're familiar with. We know that recovery management checkups are really helpful and have a big impact. These are time-limited case management services for persons who are at high risk. For example, those with chronic substance use disorders, persons with a history of homelessness, opioid use disordered individuals who have overdosed in the past. It's really important to provide intensive case management services for those people at the point of release and reentry. Also, critical time interventions, important as well. And these are also using case management services to attract people, provide addiction management, chronic illness services for both mental and substance use disorders. We look at case management. Here's some data from the Illinois Task Program. And we know that providing case management during reentry is critically important. You have to have kind of a warm handoff and someone who's going to provide transportation, housing supports, connection to substance use treatment and mental health treatment, of course. So we know that with case management services that we can really increase the rates of treatment enrollment, retention, and graduation or completion. Also, large decreases in public safety risk for people who receive case management services. And this is during, if you notice, during a 7-year follow-up period, that we have a significant reduction in reincarceration if we provide case management as part of our reentry services. And finally, family reunification for people who are oftentimes disconnected with their family for different reasons. Case management is helpful to provide connection to support family services, family counseling, other types of services to help in family reunification. So let's move and look at screening and assessment during reentry process. We've looked at the importance of reentry services, and all of you, I think, are very familiar with that. I believe that screening and assessment during this process is the foundation for providing a full, comprehensive set of reentry services. Because without that, we really don't have much a basis for making reentry plans and providing the appropriate services. First off, we know that we have extremely high rates of behavioral health disorders in the justice system, and particularly during reentry. We have, we'll look at this later, but people who have high rates of substance use disorders, mental health disorders, other chronic health disorders as well. We know that at reentry, if these undetected disorders are not assessed, or not screened, are not identified for intensive services, that these individuals are going to be rearrested and cycle back through the justice system, back through the very expensive correctional system in our states and the federal system. Perhaps most importantly, that screening assessment allows us to plan for reentry services and to link people to critical services they need during reintegration to the community. And this means there's a whole range of types of services that we need to link people to, right? And we mentioned some of those before: housing, financial support, employment, training, full-time and part-time employment, but also obviously for behavioral health care services. We know that comprehensive assessment in justice settings, including at reentry, lead to significantly better outcomes in our programs. One last thing I'll mention, and we'll return to this again, is that when we provide accurate screening and assessment at the point of reentry, we're able to gauge and justify the need for reentry services in our different settings. It could be probation, parole, the transition treatment centers we talked about, the specialized programs for recovery management. So I think having this data helps us to justify the need for increasing services and for filling the gap for people who otherwise would cycle back into the justice system without that type of care and services. Let's look at the prevalence rates for drug and alcohol use disorders in the justice system generally. So this comes from fairly recent data, and we're looking at the gender differences here for alcohol use disorders and drug use disorders. The first thing we recognize is that these rates are significantly higher than in the general population. And again, this is international data across multiple countries. I would say in the United States, the rates of these disorders are even a bit higher. You'll notice from the this right-hand side of the graph, there are significant gender differences too for women. So we find that in the justice system, the prevalence rates for drug use disorders for women are quite higher than for men. And so we need to take caution in reentry planning to make sure that we provide a good assessment for drug use disorders for both men and women and provide adequate care following that. And recognizing that women may need actually more intensive services in some cases. What about in the US? Let's take a look at this. Both in jails and state prisons, we also find high rates of substance use disorders. In fact, over half of people in the justice system in incarcerated settings in the US have a bona fide substance use disorder that is in need of treatment. If you look at the left-hand side of the graph, you'll see for the general population, the rates on the right-hand side in incarcerated settings are much, much higher. So we have sometimes 25 times the rates of these disorders in incarcerated settings, including at reentry, that we need to account for and provide services. It's important to note also that fewer than 10% of these individuals actually receive evidence-based treatment services in jails or prisons. When I say 10%, it's actually 10% receiving any type of services. And oftentimes this could be a 12-step group or peer-led services that don't rise to the level or the threshold of evidence-based services. So we know that when we get to the point of reentry, there are many, many people, even if they're assessed for substance use disorders, who are going to need evidence-based treatment and adequate care after they leave the jail or prison environment. Also of note, we did a study years ago looking at 18,000 arrestees in the US justice system, and we found very few of those had ever received treatment before. And so it's interesting. We need to also take into consideration that there's an induction process for alerting people to the benefits of treatment, both in incarcerated settings, but also following release from custody, and providing motivation, but also exploring the benefits and minimizing the risks through an accurate depiction of what goes on after people are assessed for substance use disorders. So again, really important to consider these factors. Most people have not received treatment in the past. When they're in jails and prisons, they don't receive treatment. If they do receive treatment, it's typically not evidence-based care. So for us, I think there's a big onus responsibility to provide continuity of care to intensive, appropriate, evidence-based substance use disorder treatment in the community following release. One thing to notice here is that, as you might guess, this is somewhat intuitive. For people who have more severe substance use disorders, they're more likely to be reincarcerated after release from prison during reentry. And so, again, you see kind of a linear pattern here. The more severe substance use disorders, the higher rates of recidivism, right? And reincarceration to jails and prisons. So I think this graph for me illustrates the need to screen and assess for substance use disorders prior to release, and also to prioritize more intensive case management and treatment services for those in reentry who have the more severe disorders, right? So I think we're not talking about just a screening during reentry. We're talking about a screening followed by assessment that would allow us to titrate services and to identify and prioritize level of care for persons who have more severe disorders, and to prioritize our more intensive services. It could be reentry courts, transition treatment centers, halfway houses, work release programs. We want to prioritize those for people with more severe substance use disorders. I'll pass through this slide really quickly, but again, I want to just mention briefly that when we collect data in our jails and prisons at the point of reentry, or anywhere during the reentry process, we're also helping to identify the prevalence of substance use disorders among this population, the severity of substance use disorders in our reentry population, and to provide data on the need for reentry services. I work internationally quite a bit with the State Department right now, with the United Nations, the Colombo Plan, particularly working with low and middle income countries. And in almost all of those countries, there's not an existing database about the prevalence of drug use disorders. And so it's very difficult to say, hey, we need more resources in prisons or during reentry and in the community for criminal justice populations. And I think the same is true for many of our incarcerated settings and reentry programs. We need to have that data and provide reporting about what it is that we need based on the findings about prevalence rates, severity of the disorders, the multiple needs of this population, and the need for case management intensive services. The other thing I'll mention that's really not on this graph is that screening and assessment during the reentry process can also help with early release and parole decisions, right? So we'll look at criminal risk in a little bit during the presentation today, but certainly information about criminal risk for future recidivism, as well as the need for substance use disorders treatment, are very important in terms of release decision-making and linking people to appropriate services as well. So just a couple points to mention there. I helped co-author a monograph that I believe the last publication date for the 3rd edition of this monograph was in 2019, published by SAMHSA and available free of charge on the SAMHSA website. I believe somebody just posted in the chat the link for this. Well, it's also here on the slide. And this monograph goes into some detail about instruments, approaches for screening and assessment in the justice system for both substance use disorders and also mental disorders, other types of disorders as well. Does not go into the area of criminal risk in much detail, but you'll find a comparison, for example, of different instruments for substance use disorder screening and looking at whether these instruments have been tested in the criminal justice system, their efficacy and use versus other instruments, that type of thing. So I think you might find this useful information. So when I work with different groups in training and consultation, I advocate for universal screening in the justice system and during reentry for these types of areas. And clearly, we talked about substance use disorders. We talked about the high prevalence rates of mental disorders already. We'll go into that in a little more detail. We also have very high rates of trauma and post-traumatic stress disorder, right? And I think I'm preaching to the choir here that everyone is familiar with the high rates. I know that when I started gathering data for the Hillsborough County Sheriff's Office, as we developed the first in-jail substance use treatment program here in Tampa, Florida, I was stunned after we gathered hundreds and then thousands of addiction severity index results from male and female inmates at the high rates of trauma reported, self-reported by people on the ASI. And so in our findings, we had 75% of women and over 50% of men reporting a history of trauma and post-traumatic stress disorder. So again, the need for universal screening at different points in the justice system, and particularly at intake and reception at both jails and prisons, and then certainly at the point of reentry. And that could be during reentry planning, but also as a person transitions from prison, let's say, to a program in the community providing follow-up treatment services. So each of these areas, I think, is really critical to provide screening and follow-up assessment as needed. Criminal risk we'll look at in the next few minutes. Here we're talking about the risk for future arrest. And there are many instruments. We'll name a few as we go through the presentation today. So again, just the importance of providing a screening and follow-up assessment for everyone during the reentry process because of the high rates of these disorders. And in the case of criminal risk, the importance of looking at criminal risk as a way to provide pre-release planning and post-release placement and services. Other areas that we want to look at in addition to those kind of key 4 areas include withdrawal severity. We'll talk about that later in a few minutes. And some of the other areas here that all can undermine placement in reentry services and in supervision, community supervision, whether that's probation or parole, following release from custody. So in the risk-need responsivity model, you might be familiar with the term responsivity, and these would be responsivity factors that all are barriers to engagement in evidence-based treatment. So again, if you don't have housing is maybe the single most important factor, right? As we look at reentry for people that have a history of homelessness or don't have stable housing at point of release, very hard to engage somebody in effective reentry services to keep them sober and to keep them out of the justice system without stable housing. Transportation, really important. All of these areas are things to consider. And I would mention that not only are these barriers to treatment, but these should be the subject of assessment as we look at pre-release from jails or prisons and reentry to community services at the point of intake to a community-based treatment provider. What are some considerations for screening? I'll go over these very quickly. We want to use standardized instruments that have scoring procedures, scoring criteria, thresholds, etc. We want reliable and valid instruments that have been tested in the criminal justice system and hopefully with reentry populations in the justice system. There's a lot of instruments that require more training that are not so easy to use, and so we need to look at those kind of basic, kind of practical considerations. And then, of course, cost and availability. There are so many instruments out there, many of them are expensive and maybe not more effective than public domain instruments that are free of charge. We also, again, want to look at the psychometric properties of reliability and validity in criminal justice settings. And I'll just mention that some of the instruments that you may be familiar with have not been validated in criminal justice settings and may not have also been validated for gender differences or for differences in ethnicity and racial background of individuals. So very important to look at these considerations. These are described in the monograph that I mentioned earlier that's published by SAMHSA and the Gaines Center as well. Very briefly, I'll skip over this quickly, but there's so many instruments out there. Again, there's a lot of non-standardized instruments. In the work that I've done in the past for the Gaines Center and also for the Justice Department in the US, other organizations, All Rise or NADCP, I've done quite a few site visits, and I'm always shocked, but I guess not as shocked anymore as visiting programs that have developed their own instruments without much research or data about the validity or reliability when they're used with different administrators, right? And so we want to be able to use instruments, again, that are not homegrown instruments, but that are ones that have been tested already and that have bona fide characteristics of reliability and validity in justice settings. Many of the instruments, we don't have comparative data about their effectiveness in comparison to other like instruments. For example, several screening instruments. What are the outcomes of these different instruments in predicting different substance use disorders? For example, a DSM-5, a diagnosis of a substance use disorder. We oftentimes don't have that comparative data about the outcomes of one instrument versus another. So it makes it a little bit challenging to decide which instruments are best. And then we have some instruments that have direct-to-consumer marketing of instruments that may not have the best psychometric properties, but yet are very commonly used and are quite well known because oftentimes they're at the conferences as you walk in the areas for the different booths and so forth. So just some considerations to keep in mind here as we look at which instruments to use. And I'll give you some examples of some of the public domain instruments here as we go forward. So what about screening instruments for substance use disorders? I'll point to just a few, and again, there's so much literature on these. Probably the most commonly used instrument in the United States justice system at this point is the TCUDS-5, the Texas Christian University Drug Screen 5, which is modeled after DSM-5 diagnostic criteria. And this has also been used internationally quite a bit. There's 11 scored items. There's also more information about frequency of use and an opioid use disorder supplement that we'll look at in just a minute that can be used as well. Has very good psychometric properties of reliability and validity, including use in the criminal justice system. These other two instruments are also really important and useful. They're public domain instruments free of charge. The assist was developed by the World Health Organization, and many of you may be familiar with the SBIRT system, a screening and brief intervention system that goes hand in hand with the assist screening instrument to provide an estimate of what type of services are needed for people with varying different levels of severity of substance use disorders. So again, each of these are very quick to administer, free of charge. Scoring criteria are straightforward. So these are ones I recommend, but there are also many others. The Global Appraisal of Individual Needs, for example, is a commercially available instrument with good psychometric properties, and there are plenty of others that can be used as an alternative to public domain instruments. Here are some of the assessment instruments that are available. If you look at the GAIN instrument, again, these are ones that are commercially available. I don't believe the expense is incredibly high. There are good properties, psychometric properties for the GAIN set of instruments. The Addiction Severity Index is probably the most commonly used assessment or brief assessment instrument, at least used internationally and in the US. Although I think many programs are now using the Texas Christian University short forms, brief intake forms, or the more comprehensive assessment forms for substance use disorders. For those of you that haven't visited the TCU, Texas Christian University Institute for Behavioral Research website, I'd highly recommend it. There are a number of public domain, free of charge instruments available there, including the TCUDs, which we just talked about, scoring provisions for the TCUDs, but also these assessment instruments that are listed here at the bottom of this chart as well. For those interested in treatment interventions, there's also a host of modules and manualized treatments for different types of disorders that are found in the criminal justice system with this population that we're working with during reentry. So I think it's really important to look at specific approaches for opioid use. And this is not only true in the US, but also internationally. We see synthetic opioid use really prevalent in the United States, leading to over 100,000 overdose deaths in the US in previous years. Fentanyl being the primary synthetic agent that's causing this harm. There hasn't been this widespread emergence of synthetic opioid use in other countries, although it is beginning to emerge in Egypt and other countries in Western Europe as well. So we'll see that as an increasing problem. But street heroin is, of course, a problem in almost every country and in the United States, but overtaken now by synthetic opioid use in the United States. Very briefly, I think all of you are probably familiar with the importance of providing a screening assessment for opioid use disorders. We'll look at some specific strategies for doing that in the next few minutes. We have, again, very high prevalence rates of these disorders, very high risk for overdose, relapse, and recidivism during reentry for people that have opioid use disorders, and important at the point of intake and reception in custody settings, but also at the point of reentry services to assess for opioid use disorders and to plan for that during reentry planning. These individuals oftentimes are more difficult to engage in treatment and require specific engagement strategies. We have higher dropout rates, and so we need different induction strategies for these individuals. Obviously, elevated risk for overdose and mortality. The research shows that in the first month, and certainly in the first 90 days after incarceration, we have the highest risk for overdose among people with opioid use disorders. Oftentimes, this is a function of the tolerance levels that have now been reduced for people who have been in incarcerated settings. And yet, they go out into the community and are trying to use the same level of either synthetic or street heroin that they used before, leading to a much higher risk for overdose. So I think this speaks to not only screening and assessment, but also to interventions, including just education about the tolerance levels, the greater risk for mortality and overdose for people who have opioid use disorders who are returning during the reentry process. And so I think this is an important part of the treatment strategies we need to use during reentry, both at the immediate point of release and before release from jails and prisons, but also certainly as they connect with services in the community. We also have high rates of co-occurring mental disorders and risky behaviors for this population. And we know that providing specific assessment approaches for this population leads to better outcomes, including more effective engagement in reentry services and connection with intake counselors, triage to specialized services, and involvement in medication-assisted treatment and intensive psychosocial treatment. Drug testing, really important to get rapid drug test results, particularly during reentry. Testing for fentanyl, giving you an indication for the likelihood for overdose among this population. And then, of course, positive tests for opioids during reentry should trigger screening for withdrawal and the use of MAT among this population. So, and again, I think during that window, that 90-day window that we talked about during reentry is so important to provide a rapid and repeated frequent drug testing for persons with opioid use disorders and all disorders, but particularly those with opioid use disorders because of the high risk for mortality and overdose. As I mentioned, the TCUDS-5 has a specific opioid use disorders supplement, and I won't go into great detail, but here are the components of that specific supplement. It's a 2-page supplement to the first 3 pages of the TCUDS-5. If you find that, again, on the TCU IBR, Institute for Behavioral Research website, you'll find the instrument and the scoring criteria. And again, here are some of the elements of that opioid supplement in the TCUDS. There's also specific screening strategies for withdrawal severity. And this would be at the point of reentry for people that may have resumed use of opiates, for example, who are in a reentry treatment program. I won't go into a lot of detail, but we have specific withdrawal severity instruments for opiates and also alcohol use. These are very quick to administer. They review the signs and symptoms of withdrawal from the specific type of disorders and have scoring criteria that yield whether people have mild, moderate, or severe withdrawal kind of syndromes, likelihood of that, and also the need to guide the dosage for withdrawal induction and to help place people into medication-assisted treatment as well. So these are some instruments to consider during the reentry process for people that may be resuming their opioid use at different points. Wow, what are some clinical strategies for opioid use disorders during reentry as people migrate into treatment programs in the community following release from custody? Certainly, I think there's a high level of distrust among people with opioid use disorders for people who are working with them in treatment settings. So we need to have a welcoming, non-judgmental approach. We want to acknowledge that they may not be feeling well, particularly if they've used again or now at the point of returning to abstinence after a period of opioid use in the community. We want to use recovery support specialists to help during that connection to treatment services, also to help provide information about medication-assisted treatment and the importance of involvement with methadone, buprenorphine, naltrexone, those type of interventions. We have specific opioid intervention staff now at different community treatment centers in reentry settings, which are really important, providing specialized staff who conduct intakes for persons with opioid use disorders, who can flag people who are at high need and high risk for specific services. Again, education about MAT is really useful. A lot of people may not have been exposed to MAT in prisons. I think MAT is probably used more often in Western Europe and other types of settings outside the United States, in custody settings. I think it's beginning to be much more accepted in the United States, in prisons, and even in jail settings as well. So education about that is important because, a lot of people may not have been exposed to MAT or learned about it while they're in a custody setting. So during reentry, we need to make this, this point of intervention. And then beginning transition planning at intake again. Other targeted areas for assessment, we talked about withdrawal severity, interactions with other drugs, when people are resuming perhaps their opioid use. Other areas to consider during the assessment for opioid use disorders in the reentry process. And just some other considerations. Again, your typical types of things you would include in assessment for people with other types of disorders as well. Justice system involvement history, their involvement in the child welfare system, different functional mapping of why they have started use and what are the factors that allow people to engage and continue using opioids. And then, of course, level of care required, using an ASAM criteria for placement in specific treatment services. Certainly, we need to address mental disorders as well during the reentry process, again, because of the fact that the high rates of these disorders in the justice system. If you look at the left-hand side, these are people with mental health problems, not necessarily diagnosable disorders, but mental health problems in the justice system, both in jails and in state and federal prisons as compared to the general population. So at least half of individuals have major problems with severe disorders on the mental disorders in the justice system, in custody settings, as compared to the general population. Here are some of the specific disorders that you can see at the left-hand side: depressive disorders, then bipolar and schizophrenia and post-traumatic stress disorders, with the blue bars being persons in custody settings and the red bars being in the general population. And so what you see are very high rates of these diagnosable now. These are diagnosable disorders in the justice system. Before we were talking about just general mental major mental health problems. Now we're talking about diagnosable problems. So again, for depression, we have about 3 times the rate as in the general population. For bipolar disorder, about 20 times the rate that we find in custody settings. Schizophrenia, about 10 times the rate in custody settings. And finally, post-traumatic stress disorder, 3 to 7 times the rate in the justice setting. Again, these rates here, I would say, are an underestimate of the overall diagnosable rates of post-traumatic stress disorder in the justice system. So again, the need for a specific screening and assessment, involvement of mental health clinicians, mental health staff in our reentry programs. Here are some of the instruments for screening. Again, these are all public domain instruments. I won't go into detail with these, but they are all available on the internet and are very easy to administer. They don't require a trained clinician to administer these instruments, and they can be done fairly quickly as a proxy and estimate for whether or not a person needs further assessment for their mental disorders. A screening for trauma, again, because of the high prevalence rates, we want to have universal screening for trauma in our reentry settings. Everyone should be screened. The initial screen doesn't have to be by a psychiatrist or psychologist or a licensed social worker, but it can be by someone who is just trained in use of the instruments However, the referral for assessment obviously needs to be done by a trained clinician who have experience with trauma and can refer to evidence-based programs that provide trauma-based care. The good news, again, there's many non-commercial instruments that are available. I won't spend a lot of time, but we will give you some examples. And the monograph mentioned before has some examples of these instruments. Again, positive screens for post-traumatic stress disorder and trauma need to be followed up by a full-blown assessment. So here are some of the instruments for use, both screening, assessment, and diagnosis of trauma and post-traumatic stress disorder. Typically, might be a three-stage process for doing this. One is just looking at the history of trauma events that have occurred. So, as you know, in the justice system, in custody settings and reentry settings, people that have been exposed to trauma oftentimes have not experienced just one traumatic stressor, but more than one. And so these trauma history screen, for example, or the life stressor checklist are examples of instruments that provide just in a review of what exactly have been those type of trauma events that then have led to the symptoms that are detected in the screens that you see down below, including the PCL5, which I think is one of the more commonly used screening instruments for post-traumatic stress disorder. Again, these are primarily public domain instruments. The PCL5, for example, is again mapping onto DSM-5. It's available, developed by the VA system, which has a very intensive and well thought through and researched set of instruments for trauma and post-traumatic stress disorder. So I'd encourage you to look at these instruments in more detail. And then following at the bottom are the diagnostic instruments that go into more detail. After you've determined that people have a set of symptoms for these disorders, looking at the diagnostic criteria for DSM-5 in more detail. Criminal risk, we could spend a lot of time talking about this, and I know that a lot of the reentry programs you're familiar with now are doing a criminal risk screening and assessment as a routine process during pre-release and also at the point of reentry in the community. So again, criminal risk is really important to match the level of services, both supervision and treatment, to the risk for future arrest that can be determined by the instruments that we'll look at in just a minute. We know that there's improved outcomes, for example, during reentry and other types of settings in the justice system. If we focus our intensive resources, our intensive reentry resources in this case, on those that have moderate to high risk for future arrest. We know that providing intensive treatment and supervision for low-risk offenders can actually lead to elevated risk for arrest among this population because we're mixing people who have low risk and high risk, and that we're exposing people to those that have greater criminal types of thinking processes and have greater histories of criminal risk. So again, this is contraindicated to provide to mix people with these different kind of risk levels, but also very important to identify people with moderate to high risk for rearrest so that we can prioritize our intensive services for this population. I'm going to go ahead and just scroll through all of these items, sorry. So again, we want to, in terms of risk assessment, we want to focus on the dynamic risk factors that are independent contributors to the risk for future arrest. And as it turns out, as you know, I think there's a lot of evidence about which factors are predictive of future arrest. We'll show those on the next slide. And one of these, of course, is substance use disorders, but there's many others that need to be addressed during the screening and assessment process, but also during the reentry treatment process. Again, persons with low severity substance use problems don't require formal treatment. And just as the case with low criminal risk, if we have people with low severity substance use problems placed in intensive services, they oftentimes have poorer outcomes than if they were placed in just traditional services, including drug education or community service, other types of non-intensive treatment services. Here are the dynamic risk factors, again, independent contributors to the risk for future arrest. Many of these have to do with criminal attitudes, criminal peers, the antisocial personality disorder characteristics that accommodate the bulk of the risk for criminal recidivism, along with actually with criminal history. And so criminal history also needs to be included in our risk screenings and our criminal risk assessments. But also, if you look at these other factors, these also need to be included in our criminal risk screenings and assessment. Also should be part of our treatment programs during reentry to sequentially reduce the risk for rearrest and for a better community integration if we can incorporate these types of things in our treatment programs. So what are the instruments? You're probably familiar with different instruments for use in looking at criminal risk. Again, these can be used at the point of pre-release planning, but also at the point of intervention in the community during reentry. I won't go into detail on these, but some of these include both a screening and an assessment version, such as the LSI and the Ohio Risk Assessment System. The RANT is an example of primarily a screening instrument that's been used quite a bit in drug court settings. All of these instruments have very good psychometric properties in predicting arrest. And if you look at one example of this, the LSIR, which I believe is the most commonly used risk assessment instrument in the world, you'll look at the outcomes based on the scores from this instrument in terms of predicting 12-month recidivism or rearrest. So again, we find that risk scores on the LSI are very predictive of recidivism, as are the scores on each of the other instruments that I presented in the previous slide. But the scores can actually help you gauge the level of service intensity, both treatment and supervision, that are needed for persons who are released from custody and placed in reentry settings. So these risk instruments can be very helpful in both supervision and treatment planning as you develop a unified kind of a treatment plan, case plan for these individuals during the reentry process. Final slide that I have for you today to share is that in using this information about risk and clinical information combined during the reentry planning process, we want to focus on areas of dynamic risk factors that we talked about that are elevated. We want to focus on serious and chronic substance use disorders. We want to focus on persons with serious mental illness and other barriers to engagement in effective evidence-based substance use disorder treatment. We call those responsivity factors. We mentioned those earlier, including housing, education, financial supports, family engagement, other factors as well. We want to make sure that our staff during reentry are well versed and well trained in these approaches and the instruments that we've talked about, but also in the importance of risk and needs in developing risk assessment, risk screening for this population. And after we developed a good reentry plan that incorporates criminal risk, mental health disorders, substance use disorders, trauma and post-traumatic stress disorders, we want to have a unified supervision plan, a treatment plan that's aligned to address each of these factors and that also addresses the criminogenic needs that are identified in the criminal risk assessment. One thing to note is that we talked about criminal risk just at the end of the webinar today, and one area that I find in my work that people don't oftentimes conduct is a re-administered risk assessment over time. During the reentry process, I would suggest that the risk level can change dramatically for people who are engaged in services for 3, 6, 12 months of integration into community-based services. So people are getting employed, they're reunified with their family, their mental health conditions are getting better, they're on psychotropic medication, they're now becoming abstinent from their substance use disorders or reducing use, and they're now really changing the types of risk factors that we see on our risk assessment instruments. So one thing that's important to note is that we can adjust our supervision plans and our intensive treatment plans based on the level of risk assessment, but also on the level of clinical assessment that's conducted for substance use disorders and allied problems related to psychosocial needs. And so we can alter the treatment plans, we can alter the supervision plans based on the difference that we're seeing in risk level and with the different level of psychosocial treatment needs that are occurring over time during reentry. One last thing I'll note is that for evaluation purposes, I think this can be a big selling point to look at adjustments in risk and modification of risk level over time based on involvement in reentry service programs, so that you can see, for example, reductions in criminal risk level for people who are involved in programs for 6 and 12 months during the reentry process. I think this is a really marketable area to show the importance of funding reentry programs after release from custody, so that we can, another kind of indicator in addition to substance abuse, reductions in crime, but also in risk level for future crime as well. So just some points to consider. I'll leave you with the new International Consortium for Alternatives to Incarceration that I've been involved with. We just started out in March with an opening or launch at the United Nations Commission on Narcotic Drugs. I'd welcome you to join us. It's free of charge to join our network internationally. No fees are required. We have a set of webinars and resource materials that are, I think, a good supplement to what's provided by SAMHSA and the Gain Center as well. So just encourage you to take a look at the new ICADI website as well. And then, of course, thank you for your involvement today. And I hope there have been some things here that can help you with your work. And I want to congratulate you and thank you for your great work and your contributions in assisting people during the reentry process from custody.
Well, thank you so much, Dr. Peters. I know that folks got a lot out of all of the tools that you shared. That's one of the biggest questions that I receive when I go out in the field on a site visit, et cetera, is what are the tools that we use and where can we find them? So, and someone did ask, where can we find them? And you did provide the link to TCU on your slides, but could you just, briefly describe how folks might go about finding some of these other tools that you presented?
Yeah, I mean, the easy answer in our computerized age that we live in is just on the internet. And if you'll look up any of those instruments, you'll very quickly find them. I think in some cases you'll find different states that are using a version of the instrument, like the Assist, for example, or the TCU Drug Screen 5, or some of the mental health instruments. They may look differently if they're used by a certain state system, but the scoring criteria and the format should be very similar. But I think in general, that's where you find these instruments. I mentioned the monograph before that has a listing of these as well as the websites for the specific instruments. One thing I found in doing the third edition, going through three iterations of the monograph, is that these links change over time. So the links that you find in that 2019 version may be obsolete. You may have to check online to see a more recent version of that link. But Melissa, I don't know, do you have a follow-up point or question? related to that?
I think that covers it, and I'm going to ask Brianna if she will drop the link for that manuscript back in the chat, just so folks can access it. And as Dr. Peters said, the last time we updated it was in 2019, but certainly if you have any questions finding some of the tools that Dr. Peters has referenced, reach out to us here at the Game Center. We can help you look as well. So just a few other questions came in. Thank you. So Brianna just dropped the link to the manuscript in the chat. And as Dr. Peters said, there's a wealth of information as well as some links in that publication. We are also busy, and also, hate to subject people to so many screenings, but there seems to be one screening for every issue. Are there any comprehensive screening tools that you would recommend, or do you not recommend that approach?
Oh, that's a great question. Yeah, so I get that question fairly often. Is there a kind of a magic bullet or a single screening instrument that covers everything? I think the answer is probably easier to use separate screens that have been developed by the authors and that have been researched to look at the outcomes for that particular type of disorder or problem area. I think that individual screens serve the same purpose. So you end up developing a battery of multiple screens of different types that you can incorporate and format that to do a single screen. If they're public domain instruments, you can computerize that as a single instrument if you like. I don't think the authors would have any grievances with that, but I think, yeah, there is no single screen that looks at everything. There are instruments there are instruments that attempt to look at some of the different types of disorders in more detail, like the GAIN simple screener. But what you end up with is many fewer items than you would find in a screen for a next level diagnosis. So, for example, the TCADS has 11 areas that are of interest and scorable to look at the need for further assessment for substance use disorders. I think in other types of maybe multiple screening instruments, there would be far fewer items that wouldn't give you as accurate an indicator of the need for further assessment for that type of disorder.
Thank you for that. That's really helpful. Now, someone did ask, we touched on screening for mental illness. So they asked, are there any particular tools you would recommend for someone such as a probation officer who is not a clinician?
Right. Well, I believe if you look at the mental health screening instruments that were provided, we can go back on I don't know if we can go back and look at the different slides from that, but the three I mentioned are all instruments that can be used by probation officers. I think the one caveat in terms of training would be to be conversant in terminology that's used in the screening instrument. So, for example, the instrument that the GAIN Center has promoted and really has helped develop is a brief jail mental health screen. And so that's been validated in justice settings, has really good psychometric properties, very brief instrument, but it doesn't require a trained clinician to use that. So I think a probation, parole officer, community supervision officer could certainly use those instruments. The training, I think, is in the vocabulary of the types of terms for the symptoms, et cetera. But there's not a very complex set of vocabulary involved in these instruments generally. So the training is pretty minimal. It's more in the scoring criteria for the instruments that would be valuable. So I think the good news is that most instruments for substance use disorders or mental disorders doesn't require a high level of technical expertise or training.
And that truly is invaluable. Okay, so I am just going to go through the questions and make sure we are looking at some of the most relevant questions. So I don't know if you feel if this is outside the scope of this webinar. So if you don't feel like this is a good fit, then we can table this conversation for another event. However, someone did share that they were not sure about assessing folks who have been incarcerated for a while, haven't used substances in a while, but now they're being assessed for a substance use disorder and potential treatment with medication for opioid use disorders. So any comment around that or any guidance that you would feel comfortable providing in response to that?
Yeah, that's a great question. And, particularly since people in custody have been there for various different lengths of time, right? So you've got problems with memory, with recall, particularly for persons that have had active opioid use disorder in the past. Their memory and their actually recall about their patterns of use and how much they used may have kind of decayed over time if they have a 5 or 10 year sentence, for example. So I think the accuracy depends to a certain amount on the recency of use, right? And so that's one reason to have a good intake assessment at the point of admission or reception to custody, right? Because that's the point at which typically the drug use has occurred right up to the point of arrest and incarceration. The person may have been in jail for a period of time prior to incarceration in prison, but in any case, I think these are more recent events in terms of their drug use and more accurate depiction of what's gone on during the assessment process at that point. For persons with a 5 or 10 year pattern of use, let's say for opioids who have been in prison for that amount of time, you can use that intake assessment as the kind of the best proxy for evaluating the need for reentry services for that person. And so it's certainly helpful to go over those findings with the person at the point of reentry planning prior to release, to get any additional information from them that they may not have disclosed, right, during the point of reception. A lot of persons who are entering jails or prison don't want to disclose that information because they think they're going to be placed in intensive programming that may keep them from working, keep them from earning money during incarceration, may extend their incarceration in some cases. So they may not disclose that information at the point of intake. So I think there are reasons to update that assessment that may have been conducted at the point of reception, at the point of pre-release, and then, of course, during the reentry process, if persons have been involved with substances at that point, have relapsed, for example, to conduct the further assessment later on.
And I think the bottom line in my mind is that the 2 weeks following release are the most deadly 2 weeks of that person's life. And the leading cause of death 2 weeks following release is overdose death. So I think we are still learning about the science of substance use disorders, how those work in the body. And so, while we try to adhere to the DSM-5 in diagnosing folks with substance use disorders, we clearly still have more to learn because folks who may have not used for years are being released and are returning to use at high rates. So we really do want folks to get linked to the care that they need. And so just wanted to reiterate what Dr. Peters said about ensuring that you do that adequate screening and assessment at intake to really inform you in terms of where folks might be.
One other quick thing I'd mention, Melissa, is that, we talked about education prior to release for people that may have been incarcerated for a number of years. They may not be aware of the increased potency of the drugs, including, could be methamphetamine, but certainly of fentanyl and the synthetic opioids. And so what they used in terms of street heroin in the past is not the same as what they're going to be faced with when they're released from custody. So there needs to be kind of a education process. And I think peer recovery specialists are really, really critical in this process during that reentry process for that reason, because they're well aware and can talk about some of the lethal dangers of overdose. One last thing that's kind of related is that we know that from research that for people started on medication-assisted treatment in custody settings, they have a much higher rate of continuing on medication-assisted treatment following release. And that, again, is going to be a factor to minimize the risk for overdose and mortality.
That's great. Thank you for that. So we have time for a couple more questions. So folks, if you do have questions, feel free to drop those in the Q&A pod. And I did have an ask for further clarification regarding the use of tools by folks that don't have a clinical background. So I'll just read the question to you. The attendee asked, can you clarify the last topic related to tools that can be used by probation for the assessment of SUD? Was it stated that there are tools that non-clinicians can use for diagnosis, or was the information strictly related to screening? I worry that the message wasn't clear and probation may think that a risk assessment is a diagnostic tool or can provide a level of care determination. So if you would just clarify that.
Yeah, that's a great question. And thank you. I'm sorry if it wasn't clear, but what I had talked about earlier in terms of use of instruments by non-clinicians is primarily the screening instruments, right? Very brief instruments that give you kind of symptoms of a diagnosis, but do not provide a clinical diagnosis, which requires a higher degree of training, clearly, by a clinician. Similarly, the risk assessment requires a high level of training as well. And so to do that, well, both the risk screening and the risk assessment requires a training that, you can't just take that off the shelf and provide that. I think that certainly with mental disorders and substance use disorders, you can take the screening instruments and provide those by a probation officer, case manager, someone without maybe advanced clinical training, but not the assessments, right? Or the risk assessment, particularly, or the clinical assessments. Those have to be done by a trained clinician. And so, that means that those people need to be part of the team, right? Including a mental health clinician as part of the reentry team because of the high rates of those co-occurring disorders. Does that clarify it? I hope I didn't muddy the waters, but I was really talking about screening.
Yes, that person responded yes, thank you.
Thanks.
Thank you, Megan. Okay, let's see. Yep, just some chat going on there. Great, that's wonderful. So I do have some questions that aren't necessarily related to the topic of screening and assessment, but we'll get into those, maybe just a couple since we have some time. And if you feel that it's outside the scope of your expertise, that's fine. We can revisit them later. So one person was asking about how to support sustainable care, what would be involved in successful assessment and treatment. And what that made me think about was the SBIRT. And would you be comfortable sharing more about the SBIRT and how that can be applied in criminal justice programs?
Sure. I mean, the SBIRT was really developed for use in primary healthcare settings by the World Health Organization. And so it's really focused on brief interventions. So for most of the people that we see who have chronic disorders, the SBIRT approach is only going to refer people to at the kind of the top of the pyramid for a small, in general primary care settings, only a small point of the pyramid is going to be in need of intensive substance use treatment services and other behavioral healthcare services, right? As well as intensive supervision. Whereas a contrast for our people in reentry, it's not going to be a pyramid like that. It's going to be maybe an inverted pyramid where the bulk of people at the base of the pyramid are the ones who are going to need intensive interventions. And so the SBIRT model is, the use of the assist is still viable as an instrument in criminal justice settings to immediately identify the need for further assessment for substance use disorders. And that includes tobacco, by the way, as well as alcohol and other drugs. But the SBIRT system is really not one that's well equipped to deal with the more severe disorders within the justice system and for people who have high risk for rearrest and recidivism.
Thank you for that. That's really helpful. A lot of folks asking about SBIRT. And so this is the last question, and then we'll move into our closing slides. So someone named Manny asked, how do you explain to a prosecutor the validity and reliability of using the RANT for high-risk, high-need assessments? And this person asked, how can we communicate to other team members that even though a participant does not have any clinical history, they could still benefit from treatment in a drug court program just based off high risk, high need? So especially if the participant already self-reported having mental health needs. So an interesting question there. I think there's maybe more going on than what's included in the question. But I think the bottom line would be, how would you explain to a prosecutor the importance of using assessment to look at high risk, high need, and then using that to determine further programming?
Yeah, so one really important message, Melissa, I think, is that there's a need to provide criminal risk screening and assessment, but that does not replace the need for a good psychosocial clinical assessment. So let's take substance use disorders, for example. So substance use disorders or symptoms of a severe substance use disorder is part and parcel of every risk assessment instrument and every risk screen. But for example, the RANT that you indicated is a fairly brief screen used in drug court settings and other settings to look at elevated risk for recidivism. And it does that by looking at each of the independent contributors to contribute to risk for rearrest in the future. What it looks like for substance use is not enough information to actually give you a sense of whether or not that person even needs a further assessment for substance use. It's a very few types of symptoms. Similarly, even the criminal risk assessment instruments, the LSI that I mentioned, LSCMI, those do not provide the equivalent of a good clinical assessment for substance use disorders that could rise to the level of diagnosis. So if you gave the LSCMI, for example, you're not going to be able to diagnose that the person has a opioid use disorder, right? Or an alcohol use disorder, or any other substance use disorder. It's only, remember, only one part of that criminal risk determination is substance use. And so those screening instruments and even the assessment instruments don't go into as much detail as the ASI or a much more detailed one of the TCU intake instruments or more comprehensive assessment instruments that are administered, right? And also, I would say typically, the criminal risk assessments are sometimes not done by a clinician, right? So again, you don't have the clinical expertise to even make that a diagnosis. Does that help answer the question?
I think it did. Thank you very much. So yeah, once again, we're kind of coming up against that topic of, there's not one size fit all kind of assessment or screening tool. We really do have to come up with a battery of tools to use to ensure that we're linking folks with the appropriate care and level of services. So thank you so much, Dr. Peters. We're going to move into our closing slides. So folks, if you do have questions, burning questions that were not answered, you can reach out to us here at SAMHSA's Gain Center, and we'll have some contact information at the end of this webinar. But for now, for those of you who would like a certificate of attendance, we just dropped a PDF in the chat. And what you should do is click on that and follow the instructions on your device to download that certificate. And then you will personalize it with your name and use that for your personal portfolio. So there again, just click on that PDF icon in the chat and save it to your device. If we could go to the next slide, please. We do have a couple of upcoming webinars. We'd love to see you all there. On January 16th, we will be talking about providing quality treatment programming by ensuring fidelity to a treatment model. I know a lot of us don't really have time to get into the weeds and understanding what does fidelity mean? What does it mean for us to have fidelity to a model? So come to our webinar on January 16th at 1:30 Eastern, and we'll get all into that information. Following that, we will also have another webinar on January 29th, treating people who use meth or other stimulants by leveraging contingency management in criminal justice settings. So there again, another useful approach to supporting people who use stimulants, but contingency management is not used in many criminal justice programs. So we're hoping to provide an opportunity for you all to learn more about that, and that will take place January 29th at 2 p.m. Eastern. So we hope to see you there. Move to the next slide, please. Oh, we do have a poll that just popped up. If you have any information about this topic and further work that you would like to see on this topic, please provide your responses. We do use this information to plan future webinars and events and resources. So we really appreciate your input there. Next slide, please. So if you have not signed up for the Game Center's listserv, you can use this shortened URL or pull out your camera and pull up this QR code. That will take you to a web page where you can sign up for SAMHSA's Game Center's listserv, where you can learn more about our webinars. You can receive a monthly newsletter and receive information about many other resources that we provide through the Game Center. Next slide, please. And here again, if you have questions that weren't answered and you really would like to receive more support, feel free to reach out to us here at the Game Center. We receive funds from SAMHSA to provide phone-based technical assistance. So reach out to us at the toll-free number 800-311-4246, or you can go to our website and reach us and connect with us there. There's also contact information for SAMHSA if you would like to reach out to SAMHSA. So that brings us to the end of this event. Thank you so much to all of you who joined. We'll leave this screen up for a couple more moments for folks to download the webinar of attendance. And I just want to say thank you again so much to Dr. Peters for all of this wonderful information. I hope that you find it very practical and applicable as you move forward in your days. And thank you so much for all the feedback. We really appreciate it. Thank you again, Dr. Peters.